Types of fractures. Cole's fracture. A Cole's fracture is a fracture of the distal radius. The styloid process of the ulna may be involved as well. The injury usually occurs when the patient falls on an outstretched arm and hand. It is one of the most common types of fractures in adults. It most often occurs in patients over 50 years old whose bones are osteoporotic. Fragility fracture. A younger person with a Cole's fracture caused by a low energy force should be referred to an osteoporosis evaluation. Symptoms include pain in the immediate area of injury, pronounced swelling, and dorsal displacement of the distal fragment, silver fork deformity. This displacement appears as an obvious deformity of the wrist. Major complication is vascular insufficiency from edema. CTS can be a later complication. A Cole's fracture is usually managed with closed reduction of the fracture and application of a splint or cast. If displaced, the fracture is typically managed with open reduction and internal or external fixation. Nursing management includes frequent neurovascular assessment and measures to reduce edema. Provide support and protect the extremity. Encourage active movement of the thumb and fingers to reduce edema and increase venous return. Teach the patient to perform active movements of the shoulder to prevent stiffness or contracture. Humeral shaft fracture. Fractures involving the shaft of the humerus are common among young and middle-aged adults. The most common symptoms are obvious displacement of the humeral shaft, shortened extremity, abnormal mobility, and pain. Complications associated include radial nerve injury and injury to the brachial artery due to laceration, transection, or muscle spasm. Treatment depends on the specific fracture location and displacement. Non-operative treatment may include a hanging arm cast, shoulder immobilizer, sling and swathe, a type of immobilizer that prevents shoulder movement, or humeral cuff brace. The humeral cuff brace is typically used to stabilize midshaft humerus fractures. Two pieces of molded plastic are fitted together in a clamshell configuration and held together with Velcro straps. The humeral cuff brace is a good option for non-operative fracture management if the patient is at increased risk for intraoperative complications. When these devices are used, elevate the head of the bed to assist gravity in reducing the fracture. Allow the arm to hang freely when the patient is sitting or standing. Provide measures to protect the axilla and prevent skin breakdown. Carefully place absorbable composite dressing pads, e.g. ABD pads, in the axilla. Change them twice daily or as needed. Skin or skeletal traction may be used for reduction and immobilization. During the rehabilitative phase, an exercise program to improve strength and motion of the injured extremity is extremely important. Exercises should include assisted motion of the hand and fingers. The shoulder can be exercised if the fracture is stable. This helps prevent stiffness from frozen shoulder or fibrosis of the shoulder capsule. Pelvic fracture. Pelvic fractures range from relatively minor to life-threatening, depending on the mechanism of injury and associated vascular damage. Although only a small number of fractures are pelvic fractures, this type of injury is associated with a high mortality rate. Attention to more obvious injuries at the time of a traumatic event may result in oversight of pelvic injuries. Pelvic fractures may cause serious intra-abdominal injury, including laceration and hemorrhage of the urethra, bladder, or colon. They can cause acute pelvic compartment syndrome. Paralytic ileus may occur after pelvic fracture. Patients may survive the pelvic injury only to die from sepsis, FES, or VTE. Abdominal assessment may show local swelling, tenderness, deformity, unusual pelvic movement, and bruising. Assess the neurovascular condition of the lower extremities and determine associated injuries. Pelvic fractures are diagnosed by X-ray and CT scan. Treatment depends on the severity of the injury. Stable, non-displaced fractures require little intervention. Ambulation with weight bearing as tolerated is typically encouraged. Complex or displaced fractures, e.g. open book fracture, need external fixation alone or combined with ORIF, e.g. screws, often done emergently. Use extreme care in handling or moving the patient to prevent further injury. Turn the patient only when ordered by the HCP. Because a pelvic fracture can damage other organs, assess bowel and urinary elimination. Regularly perform distal neurovascular assessment. Provide back care with adequate help or while the patient is raised from the bed by independent use of a trapeze. Hip fracture. Hip fractures are common in older adults. 95% of hip fractures result from a fall. More than 320,000 patients are admitted to hospitals each year because of a hip fracture. Up to 37% of those patients die within 1 year of injury. Many older adults develop disabilities that require long-term care. By age 90, about 33% of all women and 17% of all men will have had a hip fracture. In adults over 65 years old, hip fracture occurs more often in women than in men because of osteoporosis. Hip fracture refers to a fracture of the proximal upper third of the femur, which extends 5 centimeters below the lesser trochanter. Fractures within the hip joint capsule are intracapsular fractures. Intracapsular fractures are further identified by their specific locations. 1. Capital, fracture of the head of the femur. 2. Subcapital, fracture just below the head of the femur. And 3. Transcervical, fracture of the femoral neck. These fractures, which are often associated with osteoporosis and minor trauma, are called fragility fractures. Extracapsular fractures occur outside the joint capsule. They are either 1. Intertrochanteric, in a region between the greater and lesser trochanter, or 2. Subtrochanteric, below the lesser trochanter. Most are caused by severe direct trauma or a fall. Clinical manifestations. Manifestations include external rotation, muscle spasm, shortening of the affected extremity, and severe pain and tenderness around the fracture site. Displaced femoral neck fractures may disrupt blood supply to the femoral head, resulting in avascular necrosis of the femoral head. Interprofessional care. Immediate surgery is the standard of care. Initially, the affected extremity may be immobilized with bucks traction. If the patient's physical condition needs stabilized before surgery can be done. Bucks traction can be used for 24 to 48 hours to relieve painful muscle spasms. Surgical treatment allows early mobilization and decreases the risk for major complications. The type of surgery depends on the location and severity of the fracture and the person's age. Surgical options include 1. Closed reduction with percutaneous pinning, CRPP, minimally invasive surgery to stabilize the femoral neck and head with screws. 2. Repair with internal fixation devices, e.g. hip compression screw, intramedullary devices. 3. Replacement of the femoral head with a prosthesis, partial hip replacement, or hemiarthroplasty, often used for fracture of the femoral neck. And 4. Total hip replacement, involves both the femur and the acetabulum. Nursing management, hip fracture. Nursing implementation. Preoperative care. In addition to the usual preoperative nursing care, teaching may be done in the ED. Most patients are medically stable and thus do not have an overnight preoperative period in which to receive instructions. Most people who have hip fractures are older adults. When planning treatment of the hip fracture, consider the patient's chronic health problems, e.g. diabetes, heart and pulmonary disease. Surgery may be delayed briefly until the patient's general health is stabilized. Begin to consider discharge plans because the length of stay after surgery will be no more than a few days. Before surgery, severe muscle spasms can increase pain. Analgesics or muscle relaxants, comfortable positioning unless contraindicated, and properly applied traction, if used, can help to manage the spasms. Post-operative care. Similar principles of patient care apply to any of the surgical procedures for hip fractures. In the initial post-operative period, assess vital signs, intake and output, monitor respiratory function, and encourage deep breathing and coughing. Assess pain and give pain medication. Observe the dressing and incision for signs of bleeding. Neurovascular impairment is possible. Assess the patient's extremity for 1. Color, 2. Temperature, 3. Capillary refill, 4. Distal pulses, 5. Edema, 6. Sensation, 7. Motor function, and 8. Pain. Decrease edema by elevating the leg when the patient is in bed or in a chair. Pain in the affected extremity can be reduced by maintaining limb alignment, pillows, between the patient's knees, and turning the patient to the non-operative side. Encourage the patient to use the overhead trapeze bar and the opposite side rail to help in position changes. Avoid turning the patient to the affected side unless approved by the HCP. A physical therapist can teach the patient how to transfer out of the bed to a chair. Have the patient exercise the unaffected leg in both arms. If hemiarthroplasty or total joint replacement was done by a posterior approach, incision posterior to the midline of the greater trochanter down to the femoral shaft, measures to prevent dislocation must be used. Tell the patient and caregiver about positions and activities that increase the patient's risk for dislocation. More than 90 degrees of flexion, adduction across the midline, crossing of legs and ankles, internal rotation of the hip. Many daily activities may reproduce these positions. 1. Putting on shoes and socks. 2. Crossing the legs or feet while seated. 3. Assuming the side-lying position incorrectly. 4. Standing up or sitting down while the hip is flexed more than 90 degrees relative to the chair. And 5. Sitting on low seats, especially low toilet seats. Teach the patient to avoid these activities until the soft tissue capsule around the hip has healed enough to stabilize the prosthesis, usually at least 6 weeks. Elevated toilet seats and chair alterations, e.g. raising the seat with a folded blanket, keeping a straight back, are needed. Avoid placing a soft pillow in the patient's seat because sitting on it can cause internal rotation. If a foam abduction wedge is ordered to prevent joint dislocation, place it between the patient's legs. Apply the top straps above the knees to avoid putting pressure on the peroneal nerve at the lateral tibial tubercle. Some HCPs want the patient to keep the abductor wedge in place except when bathing or walking. If hemiarthroplasty or total joint replacement was done by an anterior approach, incision is made in the front of the hip with patient lying on the back. The hip muscles are left intact. This approach generally provides a more stable hip in the post-operative period with a lower rate of complications. Precautions related to motion and weight bearing are few. They typically include instructions to avoid hyperextension. Weight bearing on the involved extremity varies. Limited weight bearing is typically the only restriction for the patient who had ORIF of the hip fracture. Weight bearing after ORIF is generally restricted until X-ray examination shows adequate healing, usually 6 to 12 weeks. Tell the patient and caregiver about the weight-bearing status after surgery. Taking a tub bath and driving a car are not allowed for 4 to 6 weeks. An occupational therapist, OT, may teach the patient to use assistive devices, such as long-handled shoe horns, sock assists, and reachers or grabbers, to avoid bending over to pick up something on the floor. The knees must be kept apart. Teach the patient to never cross the legs or twist to reach behind. The physical therapist usually supervises exercises for the affected extremity and ambulation when the HCP allows it. The patient is usually out of bed the first postoperative day. In collaboration with the physical therapist, monitor the patient's ambulation for proper use of crutches or a walker. To be discharged home, the patient must show proper use of crutches or a walker over a functional distance, about 150 feet. The patient must be able to transfer to and from a chair and bed and to go up and down stairs. Complications associated with femoral neck fracture include non-union, avascular necrosis, dislocation, and osteoarthritis. The affected leg may be shorter if the patient had an introchanteric fracture. A cane or shoe lift may be needed for safe ambulation. Sudden severe pain, a lump in the buttock, limb shortening, and external rotation indicate prosthesis dislocation. This requires closed reduction with moderate to deep sedation or open reduction under general anesthesia to realign the femoral head in the acetabulum. If any of these signs occur, regardless of the setting, keep the patient NPO in anticipation of surgical intervention. Help the patient and caregiver to adjust to restrictions and dependence because of the hip fracture. Anxiety and depression may easily occur, but creative nursing care and awareness of potential problems can help to prevent them. Tell the patient and caregiver about community services that can help with rehabilitation after hospital discharge. Ambulatory care. Hospitalization averages 3 or 4 days. Older adults or patients who live alone may require care in a subacute rehabilitation unit, at a skilled nursing facility, or in an acute rehabilitation facility for a few weeks before returning home. If the patient has skilled nursing needs or is homebound for PT after discharge from post-acute care, the HCP may order follow-up home health care. Home care considerations include ongoing assessment of pain management, monitoring for infection, and prevention of VTE. If incision is closed with metal staples, they will be removed at the HCP's office. Teach the patient who is receiving an anticoagulant to report signs of bleeding to the HCP. Review how to administer an injectable anticoagulant if needed. Teach the patient receiving warfarin about required laboratory testing. Exercises to restore strength and tone in the quadriceps and muscles around the hip are essential to improve function and ROM. These include quadriceps setting, e.g. pressing the kneecap down, gluteal muscle setting, e.g. tightening the buttocks, leg raises in supine and prone positions, and abduction exercises from the supine and standing positions, e.g. swinging the leg out but never crossing midline. The patient continues these exercises for many months after discharge. Teach the exercise program to the caregiver, who will be encouraging the patient at home. A physical therapist assesses ROM, ambulation, and adherence to the exercise program. Patient gradually increases the number of exercise repetitions, may add ankle weights. Swimming and stationary cycling may tone quadriceps and improve cardiovascular fitness. Teach the patient to avoid high-impact exercises and sports, such as jogging and tennis, because they may loosen the implant. A physical therapist may perform a home assessment to identify hazards that may cause the patient to fall again. Evaluation. Expected outcomes. Report satisfactory pain management, have uncomplicated bone healing, take part in exercise therapy. Gerontologic considerations, hip fracture. Factors that increase the risk for hip fracture in older adults include 1. Increased risk for falling due to an altered center of gravity and inability to correct a postural imbalance. 2. Decreased fat and muscle to act as local tissue shock absorbers. And 3. Reduced skeletal strength. Other factors that increase the older adult's risk for falling include 1. Gait and balance problems. 2. Altered vision and hearing. 3. Slowed reflexes. 4. Orthostatic hypotension. And 5. Medication use. Homes can be made safer by 1. Eliminating tripping hazards, e.g. throw rugs, uneven surfaces. 2. Adding grab bars inside and outside the tub or shower and beside the toilet. 3. Adding railings on both sides of the stairs. And 4. Installing better lighting. Many falls occur when getting in or out of a chair or bed. Falls to the side, the most common type seen in frail older adults, are more likely to result in a hip fracture than a forward fall. External hip protectors may help prevent hip fractures in the frail older patient. Older adults may have low bone density osteopenia or osteoporosis, which increases their risk for fragility fractures. Calcium and vitamin D supplementation are given to patients with osteopenia or osteoporosis. A biphosphonate drug, e.g. alendronate, Fosamax, may be prescribed to decrease bone loss or increase bone density. This reduces the chances of fracture. Femoral shaft fracture. Because the femur can bend slightly to absorb stress, femoral shaft fracture occurs from a severe direct force. The force exerted to cause the fracture, e.g. from a motor vehicle crash or gunshot wound, often also damages the adjacent soft tissue. These injuries may be more serious than the bone injury. Young adults have a high incidence of this type of fracture. Displacement of fracture fragments often causes increased soft tissue damage. Considerable blood loss, 1 to 1.5 liters, can occur. The most common types of femoral shaft fracture include transverse, spiral, comminuted, oblique, and open. A femoral shaft fracture is marked by pain, notable deformity and angulation, shortening of the extremity, and inability to move the hip or knee. Complications include FES, nerve and vascular injury, and problems associated with bone union, open fracture, and soft tissue damage. Initial management involves patient stabilization and fracture mobilization. Traction may be used as a temporary measure before surgery or in the patient unable to have surgery. Placement of an intramedullary rod is the most common surgical treatment for femoral shaft fracture. The metal rod is placed into the marrow canal of the femur. The rod passes across the fracture to keep fragments in position. Plates and screws also may be used. Internal fixation is preferred because it reduces the hospital stay and complications associated with prolonged bed rest. External fixation may be used for an open fracture. After surgery, gluteal and quadriceps isometric exercises will promote and maintain strength in the affected extremity. Encourage the patient to perform ROM and strengthening exercises for all uninvolved extremities to prepare for ambulation. Patient may be allowed to begin non-weight bearing activities with an assistive device, e.g. walker, crutches, Full weight bearing is usually restricted until X-rays show union of fracture fragments. Teach the patient to carefully follow the HCP's instructions for weight bearing. Tibial fracture. Although the tibia is vulnerable to injury because it lacks a covering of anterior muscle, strong force is needed to cause a fracture. As a result, soft tissue damage, devascularization, and open fracture are common. Tibia is also a common site for stress fracture. Complications of tibial fractures include compartment syndrome, FES, delayed union or non-union, and possible infection with an open fracture. Recommended management for closed tibial fractures is closed reduction followed by immobilization and a long leg cast. ORIF with intramedullary rods, plate fixation, or external fixation is needed for complex fractures and those with extensive soft tissue damage. An emphasis of care is maintaining quadriceps strength. Assess the neurovascular condition of the affected extremity at least every 2 hours during the first 48 hours. Have the patient perform active ROM exercises with the uninvolved leg and the upper extremities to build the strength needed for crutch walking. When the HCP has determined the patient is ready for gait training, review principles of crutch walking introduced by the physical therapist. The patient may be non-weight bearing for 6 to 12 weeks, depending on healing. Home nursing visits may be needed to monitor the patient's progress if the patient is homebound. Stable vertebral fracture. In a stable fracture, fracture fragments are unlikely to move or cause spinal cord damage. This type of injury is often confined to the vertebral body, anterior part of the spinal column, in the lumbar region. Sometimes it involves the cervical and thoracic regions. Vertebral bodies are usually protected from displacement by intact spinal ligaments. Stable fractures of the vertebral column are usually caused by motor vehicle crashes, falls, diving, or sports injuries. Patients with osteoporosis have more than 700,000 vertebral compression fractures annually, many of which are stable. Most patients with stable fractures have only brief periods of disability. However, if spinal ligaments are significantly disrupted, dislocation of the vertebrae may occur. Instability and injury to the spinal cord may result on stable fracture. These injuries generally require surgery. The most serious complication of vertebral fractures is fracture displacement, which can cause damage to the spinal cord. Although stable vertebral fractures are not associated with abnormal spinal cord pathology, all spinal injuries should be considered unstable and potentially serious until diagnostic tests determine the fracture to be stable. The patient usually has pain and tenderness in the affected region of the spine. There may be a kyphotic deformity, flexion angulation of thoracic vertebrae, known as Dowager's hump. This deformity is readily identified during the physical examination. Lordosis, extreme inward curve of lumbar spine, and cervical spine involvement are possible. Sudden loss of function below the fracture indicates spinal cord impingement or paraplegia. Bowel and bladder dysfunction may occur if there is interruption of the autonomic nervous system, nerves, or injury to the spinal cord. The overall goal in managing stable vertebral fractures is to keep the spine in good alignment until union is achieved. Many nursing interventions are aimed at assessing for spinal cord trauma. Regularly evaluate vital signs and bowel and bladder function. Monitor the motor and sensory function of peripheral nerves distal to the injured region. Promptly report any deterioration in the patient's neurovascular condition. Treatment includes pain medication followed by early mobilization and bracing. The patient's mattress should be firm to support the spinal column, relax muscles, decrease edema, prevent potential compression on nerve roots. Teach the patient to keep the spine straight when turning by moving the shoulders and pelvis together. The patient will need nursing help to learn the technique of log rolling. Several days after the initial injury, the HCP may apply a specifically constructed orthotic device, e.g. thoracolumbar sacral orthosis, a jacket cast, or a removable corset. There is no evidence of neurologic deficit. The device gives extra support during healing and is used for a short period of time. Lightweight bracing, e.g. Jewett or Baylor Vogt brace, may be used for patients with stable vertebral compression fractures due to osteoporosis. Patients with osteoporosis also may be treated with 2 outpatient procedures, vertebroplasty or balloon kyphoplasty. Vertebroplasty uses radioimaging to guide the injection of bone cement into a fractured vertebral body. Kyphoplasty is now the surgical treatment of choice for compression fractures. This is due to the decreased incidence of bone cement leakage into nearby structures, e.g. colon, lung, compared to vertebroplasty. Patients have decreased pain almost at once with these procedures. However, later compression fractures of adjacent vertebrae are a risk. If the fracture is in the cervical spine, the patient may wear a hard cervical collar. Some cervical fractures are immobilized by use of a halo vest. This consists of a plastic jacket or cast fitted about the chest and attached to a halo held in place by skeletal pins inserted into the cranium. These devices immobilize the spine in the fracture area while allowing the patient to ambulate. Patient with a stable vertebral fracture is discharged after 1. Showing safe ambulation, 2. Learning care of the cast or orthotic device, and 3. Stating ways to address safety and security concerns related to the injury and treatment. Facial fracture. Any bone of the face can be fractured from trauma, such as a motor vehicle crash, an assault, or a fall. After facial injury, it is critically important to establish and maintain patent airway and provide adequate ventilation. Suctioning may be needed to remove foreign material and blood. A surgically created airway, tracheostomy, may be needed if a patent airway cannot be maintained. Facial fractures and cervical spine injuries often occur together. All patients with facial injuries should be treated as if they have a cervical injury until proven otherwise by examination and CT scan or X-ray. Related soft tissue injury often makes assessment of facial injury difficult. Perform oral and facial examinations after any life-threatening situations have been treated. Carefully assess ocular muscles and cranial nerves 3, 4, and 6. X-rays help determine the extent of the injury. CT scanning helps distinguish between bone and soft tissue injury. Suspect injury to the eye when facial injury occurs, especially if the injury is near the orbit. If an eye globe rupture is suspected, stop and place a protective shield over the eye. Signs of rupture include vitreous humor forced out of the eye, brown tissue, iris, or ciliary body may be seen on the surface of the globe or penetrating through a laceration with an off-center or teardrop-shaped pupil. Specific treatment depends on the site and extent of the facial fracture and associated soft tissue injury. Mobilization or surgical stabilization may be needed. Maintain a patent airway and adequate nutrition throughout the recovery period. Be sensitive about changes in appearance that may occur after a facial fracture. Changes in appearance may be drastic. Edema and discoloration subside with time. Soft tissue injuries can cause permanent scarring. Mandibular fracture. Mandibular fracture may result from trauma to the face or jaw. Maxillary fractures may also occur, but they are less common than mandibular fractures. The mandibular fracture may be simple with no bone displacement or may involve loss of tissue and bone. Fracture may need immediate treatment to ensure the patient's survival. Long-term treatment is sometimes needed to restore satisfactory appearance and function. Mandibular fractures may be done therapeutically to correct an underlying alignment problem, malocclusion, that cannot be adjusted by orthodontics alone. The mandible is resected during surgery and manipulated forward or backward to correct the occlusion problem. Surgery for a mandibular fracture includes immobilization, usually by wiring the jaws, intermaxillary fixation. Internal fixation may be done with screws and plates. In a simple fracture with no loss of teeth, lower jaw is wired to the upper jaw. Wires are placed around the teeth, and then cross wires with rubber bands are used to hold the lower jaw tight against the upper jaw. Arch bars may be placed on the maxillary and mandibular arches of the teeth. Vertical wires placed between the arch bars hold the jaws together. If teeth are missing or bone is displaced, other forms of fixation may be needed, e.g. metal arch bars in the mouth or insertion of a pin in the bone. Bone grafting may be needed. Immobilization is usually needed for only 4 to 6 weeks because the fractures often heal rapidly. Nursing management, mandibular fracture. Teach the patient before surgery about what is involved in the surgical procedure, how the face will look afterward, and changes caused by surgery. Reassure the patient about the ability to breathe normally, speak and swallow liquids. Hospitalization for respiratory monitoring is brief, unless there are other injuries or problems. Postoperative care focuses on a patent airway, oral hygiene, communication, pain management, and adequate nutrition. Two potential problems in the immediate postoperative period are airway obstruction and aspiration of vomitus. Because the patient cannot open the jaws, an airway must be maintained. Observe for signs of respiratory distress, e.g. dyspnea, changes in rate quality, death of respirations. After surgery, Place the patient on the side with the head slightly elevated. Tape a wire cutter or scissors for rubber bands to the head of the bed. Send it with the patient to all appointments and examinations away from the bedside. The wire cutter or scissors may be used to cut the wires or elastic bands in case of an emergency requiring access to the pharynx or lungs, e.g. cardiac arrest or respiratory distress. In the care plan, include a picture with the appropriate wires to cut in an emergency. In some cases, cutting the wires may cause the entire facial and upper jaw structure to shift or collapse and worsen the problem. A tracheostomy or endotracheal tray should always be available. If the patient begins to vomit or choke, try to clear the mouth and airway. Suction via the nasopharyngeal or oral route, depending on the extent of injury and type of repair. An NG tube can remove fluids and gas from the stomach to help prevent vomiting and aspiration. The NG tube can later be used as a feeding tube. Antiemetics may be given. Teach the patient to clear secretions and vomitus. Oral hygiene is very important. Teach the patient to remove food debris by rinsing the mouth often, especially after meals and snacks. Warm, normal saline solution, water, or alkaline mouthwashes may be used. A syringe and soft irrigation catheter or a water pick may be effective for thorough oral cleansing. Inspect the mouth several times a day to see that it is clean. Use a tongue depressor or retract the cheeks. Keep the lips, corners of the mouth, and buccal mucosa moist. Cover any sharp edges of the wires with dental wax to prevent irritation of the buccal mucosa. Communication may be a problem, especially in the early postoperative period. Establish an effective way to communicate before surgery, e.g. use of a dry erase board, pad, and pencil. Usually the patient can speak well enough to be understood, especially a few days after surgery. Intake of adequate nutrients may be a challenge because the diet must be liquid. The patient easily tires of sucking through a straw or laboriously using a spoon. Work with the dietitian and patient to plan a diet with adequate calories, protein, and fluids. Liquid protein supplements may improve the patient's nutrition. Low bulk, high carbohydrate diet and intake of air through the straw contribute to constipation and gas. Ambulation, prune juice, and bulk forming laxatives may help relieve these problems. The patient is usually discharged with the wires in place. Encourage the patient to share feelings about the changes in appearance. Discharge teaching should include oral care, diet, how to handle secretions, how and when to use wire cutters or scissors, and when to notify the HCP about concerns and problems. Amputation. An amputation is the removal of a body extremity by trauma or surgery. About 2 million Americans are living with limb loss. About 185,000 amputations occur each year in the United States. Most amputations are done due to PVD, especially in older patients with diabetes. These patients often have peripheral neuropathy that progresses to deep ulcers and gangrene. Amputation in young people is usually due to trauma, e.g. motor vehicle crashes, farm-related injury. Battle injuries have affected over 1,700 veterans since 2003, with several losing more than one limb. Other common reasons for amputation include thermal injuries, tumors, osteomyelitis, and congenital limb disorders. Diagnostic studies. Diagnostic studies depend on the underlying reason for the amputation. An increased white blood cell count with abnormal differential may show infection. Vascular tests such as arteriography, Doppler studies, and venography give information about circulation in the extremity. Interprofessional care. If amputation is planned or elective, as for the patient with PVD, carefully assess the patient's general health. Chronic illnesses and infection must be managed before an amputation is done. Help the patient and caregiver understand the need for the amputation. Assure them that rehabilitation can help with quality of life. If the amputation is done emergently after trauma, patient management is physically and emotionally more complicated. The goal of surgery is to preserve the greatest extremity length and function while removing all infected, pathologic, or ischemic tissue. Levels of amputation of upper and lower extremities are shown in figure 62.23. The type of amputation depends on the reason for the surgery. A closed amputation creates a weight-bearing residual limb or stump. An anterior skin flap with dissected soft tissue padding covers the bony part of the residual limb. The skin flap is sutured posteriorly so that the suture line will not be in a weight-bearing area. Take special care to prevent accumulation of drainage, which can cause pressure and harbor bacteria that may cause infection. Disarticulation is an amputation done through a joint. A Sims amputation is a form of disarticulation at the ankle. After an open amputation, guillotine amputation, the surface of the residual limb is left uncovered with skin. This type of surgery is generally done to control actual or potential infection. The wound is usually closed later by a second surgical procedure or closed by skin traction surrounding the residual limb. Nursing management amputation. Assessment. Assess for any pre-existing illnesses. Because most amputations are done for vascular problems, assessment of vascular and neurologic condition is especially important. Nursing diagnoses. Disturbed body image, impaired tissue integrity, chronic pain, impaired physical mobility. The overall goals are that the patient with an amputation will 1. Have adequate relief from the underlying health problem, 2. Have satisfactory pain management, 3. Reach maximum rehabilitation potential with the use of a prosthesis if indicated, 4. Cope with the body image changes, and 5. Make satisfying lifestyle adjustments. Nursing implementation, health promotion. Control of illnesses such as PVD, diabetes, chronic osteomyelitis, and pressure injuries can eliminate or delay the need for amputation. Teach patients with these problems to carefully examine their lower extremities daily for signs of infection or skin breakdown. If the patient cannot do this, the caregiver should help. Teach the patient and caregiver to report changes in the feet or toes to the HCP. These include decreased or absent sensations, tingling, burning pain, cuts or abrasions, and changes in skin color or temperature. Review safety precautions for people taking part in recreational activities and potentially hazardous work. This responsibility is especially important for the occupational health nurse. Acute care. Reasons for amputation and the rehabilitation potential depend on a person's age, diagnosis, occupation, personality, resources, and support system. Be aware of the tremendous psychological and social implications of amputation. Body image problems related to amputation often cause a patient to go through a grieving process. Use therapeutic communication to help the patient or caregiver through this process and develop a realistic attitude about the future. Preoperative care. Before surgery, reinforce information that the patient and caregiver have received about reasons for the amputation. Proposed prosthesis and mobility training program. To meet the patient's educational needs, know the level of amputation, type of dressings to be applied, and type of prosthesis to be used. Teach the patient to perform upper extremity exercises such as push-ups in bed or the wheelchair, to promote arm strength for crutch walking and gait training. Discuss general post-operative nursing care, including positioning support and residual limb care. If a compression bandage will be used after surgery, teach the patient about its purpose and how it will be applied. If immediate prosthesis use is planned, discuss general ambulation expectations. Tell the patient that the amputated limb may feel like it is still present after surgery. This phenomenon, termed phantom limb sensation, occurs in many amputees. Postoperative care. General care for the patient who had an amputation depends largely on the patient's age and general state of health and the reason for the amputation. Monitor patients who had an amputation due to a traumatic injury or post-traumatic stress disorder because they may have had no time to prepare or even take part in the decision to have a limb amputated. Prevention and detection of complications are important after surgery. Carefully monitor the patient's vital signs. Assess dressings for hemorrhage. Use sterile technique during dressing changes to reduce the risk for wound infection. If an immediate postoperative prosthesis has been applied, carefully observe the surgical site. If excess bleeding occurs, notify the HCP at once. Keep a surgical tourniquet available for emergency use. The delayed prosthetic fitting may be the best choice for older adults, patients with infection, or patients who have had amputations above the knee or below the elbow. Appropriate timing for the use of a prosthesis depends on satisfactory healing of the residual limb and the patient's general condition. A temporary prosthesis may be used for partial weight bearing after sutures are removed. If there are no problems, the patient can bear full weight on a permanent prosthesis about 3 months after amputation. Not all patients are candidates for prostheses. The seriously ill or debilitated patient may not have the upper body strength and energy needed to use a lower extremity prosthesis. Mobility with a wheelchair may be the most realistic goal for this patient. Patients are often extremely worried about phantom limb sensation because they still perceive pain in the missing part of the limb. As recovery and ambulation progress, phantom limb sensation and pain usually subside. However, the pain may be chronic. The patient may have shooting, burning, or crushing pain, as well as feelings of coldness, heaviness, and cramping. Unfortunately, there is no one therapy for phantom limb sensation. Mirror therapy reduces symptoms in some patients. We do not know why looking in the mirror at the remaining limb would improve symptoms. The mirror is thought to give visual information to the brain, replacing sensory feedback expected from the missing limb. Mirror therapy may also improve patient function after a stroke. Success of the rehabilitation program depends on the patient's physical and emotional health. Chronic illness and deconditioning can complicate rehabilitation. Physical and occupational therapy must be a central part of the patient's overall plan of care. Flexion contractures may delay rehabilitation. The most common and debilitating contracture is hip flexion. Hip adduction contracture is rare. To prevent flexion contractures, have patients avoid sitting in a chair for more than 1 hour with hips flexed or having pillows under the surgical extremity. Unless contraindicated, Patients should lie on their abdomen for 30 minutes, 3 or 4 times each day, and position the hip in extension while prone. Proper bandaging ensures the residual limb is shaped and molded for eventual prosthesis fitting. The HCP usually orders a compression bandage to be applied right after surgery to support soft tissues, reduce edema, hasten healing, and minimize pain. Compression also promotes residual limb shrinkage and malnutrition. This bandage may be an elastic roll applied to the residual limb or a residual limb shrinker, which is an elastic stocking that fits tightly over the residual limb. At first, the patient always wears a compression bandage except during PT and bathing. Remove and reapply the bandage several times daily. Take care to apply it snugly but not so tight as to interfere with circulation. Wash and change shrinker bandages daily. After the residual limb is healed, bandage it only when the patient is not wearing the prosthesis. Teach the patient to avoid dangling the residual limb over the bedside to decrease edema. As the patient's overall condition improves, the HCP and physical therapist start and supervise an exercise program. Active ROM exercises for all joints should be started as soon as possible after surgery. To prepare for mobility, the patient should increase triceps and shoulder strength for lower limb support. The patient will need to learn to balance the altered body. The lost weight of an amputated limb requires adaptation of the patient's proprioception and coordination to prevent falls and injury. Crutch walking starts as soon as the patient is physically able. Follow orders for weight bearing carefully to avoid injury to the skin flap and delay of tissue healing. Before discharge, teach the patient and caregiver about residual limb care, ambulation, contracture prevention, recognition of complications, exercise, and follow-up care. Ambulatory care. When healing has occurred satisfactorily and the residual limb is well molded, patient is ready for prosthesis fitting. A prosthesist makes a mold of the residual limb and measures landmarks for creation of the prosthesis. The molded limb socket allows the residual limb to fit snugly into the prosthesis. The residual limb is covered with a stocking to ensure good fit and prevent skin breakdown. If the limb continues to shrink, causing a loose fit, a new socket has to be made. The patient may need to have the prosthesis adjusted to prevent rubbing and friction between the residual limb and socket. Excessive movement of a loose prosthesis can cause severe skin irritation, breakdown, and gait problems. Artificial limbs become an integral part of the patient's changed body image. Teach the patient to clean the prosthesis socket daily with mild soap and rinse thoroughly to remove irritants. Leather and metal parts of the prosthesis should not get wet. Encourage the patient to have regular maintenance on the prosthesis. Consider the condition of the patient's shoe. A badly worn shoe alters the gait and can damage the prosthesis. Special considerations in upper limb amputation. Emotional implications of an upper limb amputation are often more devastating than for lower limb amputation. Despite technological advances, we cannot replicate the movements and functional capacity of our hands with upper extremity prostheses. The enforced dependency due to being one-handed may be depressing and frustrating to the patient. Because most upper extremity amputations result from trauma, the patient likely had little time to adjust psychologically or be a part of the decision-making process. Both immediate and delayed prosthetic fittings are possible for the below the elbow amputee. Prosthetic fitting is delayed for the above the elbow amputee. The usual functional prosthesis is the arm and hook. The cosmetic hand is available but has limited functional value. As with the lower limb prosthesis, patient motivation and perseverance are major factors contributing to a satisfactory outcome. Evaluation. The expected outcomes are that the patient with an amputation will accept changed body image and integrate changes into lifestyle, have no evidence of skin breakdown, have reduction or absence of pain, become mobile within limitations imposed by amputation. Gerontologic considerations. Amputation. If a lower limb amputation has been done on an older adult, the patient's previous ability to ambulate may affect the extent of recovery. Using a prosthesis requires significant strength and energy for ambulation. For example, walking with a below-the-knee prosthesis requires 40% more energy than walking on two legs. An above-the-knee prosthesis requires 60% more. Older adults whose general health is weakened by disorders such as heart or lung disease may not be able to use a prosthesis. Patient's ability to ambulate may be limited. If possible, discuss these issues with the patient and caregiver before surgery so that realistic expectations can be set. Common joint surgical procedures. Surgery plays a vital role in the treatment and rehabilitation of patients with various joint problems. The goals of surgery are to relieve chronic pain, improve joint motion, correct deformity and misalignment, and remove diseased cartilage. If the joint problem is not corrected, contraction with permanent limitation of motion may occur. Limited joint motion can be noted on physical examination. Joint space narrowing can be seen on x-rays. Types of joint surgeries. Synovectomy. Synovectomy, removal of synovial membrane, is done to remove inflamed tissue that is causing unacceptable pain or limiting ROM in RA. A synovectomy is best done early in the disease process when there is minimal bone or cartilage destruction. Removing the thickened synovium does not cure RA, but may relieve symptoms temporarily. Common sites for this surgery include the elbow, wrist, and fingers. Synovectomy in the knee is done less often because knee joint replacement is usually done. Osteotomy. An osteotomy involves removing a wedge or slice of bone to restore alignment, joint, and vertebral, to shift weight bearing, thus relieving pain. Cervical osteotomy may be used to correct a kyphotic deformity in patients with ankylosing spondylitis. Halo vest and body jacket braces are worn until fusion occurs, 3 to 4 months. Osteotomy is not effective in patients with inflammatory joint disease. However, femoral osteotomy may provide some pain relief and improve motion in select patients with hip osteoarthritis. Tibial osteotomy also provides pain relief in some patients with knee instability or OA. Care of a patient who had an osteotomy similar to that of a patient with ORIF of a fracture at a comparable site. Internal wires, screws, and plates, bone grafts, or an external fixator usually fixes the bone in place. Debridement. Debridement is the removal of debris such as pieces of bone or cartilage loose bodies, or osteophytes from a joint using a fiber optic arthroscope. This procedure is usually done on an outpatient basis on the knee or shoulder. A compression dressing is applied after surgery. Weight bearing is permitted after knee arthroscopy. Patient teaching includes monitoring for signs of infection, managing pain, and restricting activity for 24 to 48 hours. Arthroplasty. Arthroplasty is the reconstruction or replacement of a joint to relieve pain, improve or maintain ROM, and correct deformity. Arthroplasty is most often done on patients with OA, RA, avascular necrosis, congenital deformities or dislocations, and other systemic problems. Types of arthroplasty include surgical reshaping of the bones of the joints, replacement of part of a joint, hemiarthroplasty, and total joint replacement. Around 1 million Americans have knee and hip replacement surgery annually. Arthroplasty is also available for elbows, shoulders, fingers, wrists, ankles, and feet. Total hip arthroplasty. Total hip arthroplasty, THA, or a total hip replacement, provides significant relief of pain and improved function for patients with joint deterioration from OA, RA, and other conditions. THA is also used to treat hip fractures. In THA, the prosthesis implant replaces the ball and socket joint formed by the upper shaft of the femur and pelvis. Both the ball and socket components can be cemented in place with polymethyl methacrylate, which bonds to the bone. They may also be inserted without cement, cementless. Cementless THA may provide longer stability by enabling ingrowth of new bone tissue into the porous surface coating of the prosthesis. Cementless devices are recommended for younger, more active patients and patients with good bone quality so that bone ingrowth into the components can be readily achieved. Hip resurfacing arthroplasty. An alternative to hip replacement is hip resurfacing arthroplasty. It preserves and reshapes the femoral head, ball, rather than replacing it as a THA. The resurfaced femoral head is then capped by a metal prosthesis. Hip resurfacing may be an option for patients younger than age 60 with larger frames. A small number of patients will have a femoral neck fracture after hip resurfacing. This is not possible with THA. In addition, metal ions may be released into the bloodstream from the prosthesis. Patients may develop sensitivity or allergy to these ions. Patients receiving a smaller femoral head, including many women, have a higher failure rate with a resurfaced implant when compared with patients receiving THA. Knee arthroplasty. Unrelieved pain and instability due to severe deterioration of the knee joint are the main reasons for total knee arthroplasty, TKA, or a total knee replacement. Partial arthroplasty can be done on a patient with osteoarthritis limited to one compartment of the knee. Immediately after surgery, a compression dressing may be used to immobilize the knee in extension. This dressing is removed before discharge. If the patient is unable to perform a straight leg raise, a knee immobilizer or posterior plastic shell to maintain extension may be used during ambulation and at rest for about 4 weeks. After surgery, emphasis is on pain management and PT. Managing pain is a primary nursing goal. Doing so decreases the patient's risk for complications and hastens the return to function. Adequate analgesia should be ordered to discharge to allow the patient to continue with the exercise program. Effective pain management is key to achieving positive rehabilitation outcomes. PT begins early with isometric quadriceps setting. Therapy progresses to straight leg raises and gentle ROM to increase muscle strength and obtain 90-degree knee flexion. Active flexion exercises or passive flexion exercises with a continuous passive motion (CPM) machine may promote joint mobility. Ambulation starts early and typically progresses to full weight bearing before discharge. An active home exercise program involves progressive ROM with muscle strengthening and flexibility exercises. After TKA, many older patients with advanced OA show significant improvement in mobility, motor function tests, and ability to complete daily tasks. Finger joint arthroplasty. A silicone rubber arthroplastic device is used to restore function in the fingers of the patient with RA. Ulnar deviation often causes severe functional limitations of the hand. The goal of hand surgery is primarily to restore function related to grasp, pinch, stability, and strength rather than to correct cosmetic deformity. Before surgery, the patient is taught hand exercises including flexion, extension, abduction, and adduction of the fingers. After surgery, a bulk dressing is placed and the hand is kept elevated. Perform regular neurovascular assessment and monitor for signs of infection. Success of the surgery depends largely on the post-operative treatment plan, which is usually implemented by an OT. After the dressing is removed, a guided splinting program is started. The patient is discharged with splints to use while sleeping and hand exercises to do at least 3 or 4 times a day for 10 to 12 weeks. Teach the patient to avoid lifting heavy objects. Elbow and shoulder arthroplasty. Total replacement of elbow and shoulder joints is not as common as other forms of arthroplasty. Shoulder replacements are done in patients with severe pain because of RA, OA, avascular necrosis, or trauma. A specialized type of shoulder replacement called a reverse total shoulder arthroplasty may be done for pain and dysfunction caused by massive, irreparable rotor cuff tears. Shoulder replacement is usually considered if the patient has adequate surrounding muscle strength and bone density. Joint replacement is needed for both elbow and shoulder. The elbow is usually done first because a severely painful elbow interferes with the shoulder rehabilitation program. Most patients have no pain at rest or minimal pain with activity after elbow and shoulder arthroplasty. Functional improvements contribute to better hygiene and increased ability to perform ADLs. However, rehabilitation is longer and more difficult than with other joint surgeries. Ankle arthroplasty. Total ankle arthroplasty, TAA, is indicated for RA, OA trauma and avascular necrosis. Although use of TAA is not widespread, it is a good alternative to fusion for treatment of severe ankle arthritis in certain patients. Available devices include several fixed bearing devices and mobile bearing cementless prosthesis. This device more closely imitates natural ankle function. Ankle fusion is often done over arthroplasty because the result is more durable. However, fusion leaves the patient with a stiff foot and the inability to change heel height. TAA achieves a more normal gait pattern. After surgery, the patient may not bear weight for 6 weeks. Teach the patient to elevate the extremity to reduce edema, take steps to prevent infection, and maintain immobilization as directed by the HCP. Arthrodesis. Arthrodesis is the surgical fusion of a joint. The procedure is done only if articular surfaces are too severely damaged or infected to allow replacement, or if reconstructive surgery fails. Arthrodesis relieves pain and provides a stable but immobile joint. Fusion is usually done by removing the articular, hyaline cartilage and adding bone grafts across the joint surface. The affected joint must be immobilized until bone healing has occurred. Common areas fused are wrist, ankle, cervical spine, lumbar spine, and metatarsophalangeal (MTP) joint of the great toe. Complications of joint surgery. Infection is a serious complication of joint surgery, especially joint replacement surgery. Most common causative organisms are gram-positive aerobic streptococcus and staphylococcus. Infection may lead to pain and loosening of the prosthesis, generally requiring further surgery. Efforts to reduce infection include the use of specifically designed self-contained operating suites, operating rooms with laminar airflow, and prophylactic antibiotic administration. VTE is another potentially serious complication after joint surgeries, especially those involving the lower extremities. Provide prophylactic measures such as anticoagulant drugs, use of intermittent pneumatic compression devices, and early ambulation. Assess patients for signs of VTE. VTE is discussed in Chapter 37. Nursing and interprofessional management, joint surgery. Preoperative management. Primary goal of preoperative assessment is to identify risk factors for postoperative complications so we can implement measures to promote optimal outcomes. Careful history includes 1 medical diagnosis and complications such as diabetes and VTE, 2 pain tolerance and management preferences, 3 current functional level and expectations after surgery, 4 current social support, and 5 home care needs after discharge. Patients should be free from infection and acute joint inflammation. Preoperative teaching about the expected hospital course and postoperative management at home is important for the patient and caregiver. Explain postoperative procedures such as turning, deep breathing, use of bedpan and bedside commode, and use of an abductor pillow. Assure the patient that analgesia will be available. A preoperative PT visit allows practice of postoperative exercises and measurement for crutches or other assistive devices. Provide opportunities for practice with assistive devices. If lower extremity surgery is planned, assess upper extremity muscle strength and joint function to determine the type of assistive devices needed for ambulation and ADL performance. Discuss ways to maximize the usefulness and longevity of the prosthesis. Patients need to realize that recovery does not occur rapidly. Talking with other people who have had joint arthroplasty may help the patient better understand the reality of rehabilitation. Discharge planning begins immediately. Discuss the duration of the hospital stay and the expected postoperative events so that the patient and caregiver can prepare. Discuss the safety and accessibility of the home environment, e.g. throw rugs, cords. Are the bathroom and bedroom on the first floor? Are door frames wide enough to accommodate a walker? Assess the patient's social support. Is a friend or family member available to help the patient at home? The patient need homemaker or meal services. The older patient may need to be discharged to a subacute or extended care facility for a few weeks to regain independent living skills. Postoperative management. Regularly perform neurovascular assessment postoperatively. Give ordered anticoagulant medication, analgesia, and parenteral antibiotics. Pain management strategies may include epidural or intrathecal analgesia, femoral nerve block, patient-controlled IV analgesia, and oral opioids or NSAIDs. Assess patient comfort often during the postoperative period. Monitor for postoperative complications. Assess ROM at regular intervals to facilitate the goal of improved functional performance. In general, the affected joint is exercised and ambulation is encouraged as early as possible to prevent complications of immobility. Specific protocols vary according to the patient type of prosthesis and HCP preference. Depending on the surgical approach, an abduction pillow may be used after THA. The hospital stay after arthroplasty is about 3 days depending on the patient's course and need for PT. Some patients are discharged in 1 to 2 days. Some knee replacement surgeries are done at ambulatory surgical centers. Teach the patient to report complications including infection, e.g. fever, increased pain drainage, dislocation of the prosthesis, e.g. pain, loss of function, shortening, or misalignment of an extremity. PT and ambulation enhance mobility, build muscle strength, and reduce the risk for VTE. Prophylactic anticoagulant drugs should be given for at least 10 to 14 days. Some patients need therapy for up to 35 days. If the patient is taking warfarin, therapy starts on the day of surgery, and the INR and prothrombin times are measured daily. Therapy with LMWH, e.g. enoxaparin, apixaban, or rivaroxaban, usually starts the morning after surgery.